Welcome to the Deep Dive. Today, we're tackling a really critical area, acute ischemic stroke, or AIS.
Yeah, it's a huge global health issue.
Absolutely, a major cause of, long-term disability and, sadly, mortality worldwide. So any progress in, like, how we treat it or predict outcomes is
Yeah,
it's huge.
it really is. And we've got some pretty compelling research to dig into today. We're going to look at a study comparing different techniques for clearing clots in a specific kind of stroke, an M2 occlusion.
Okay.
And we also have another study, a fascinating one actually, using advanced MRI analysis powered by AI to try and predict how well someone might recover after treatment.
AI and stroke prediction, interesting.
Yeah, and we'll sort of tie it all together with the latest recommendations from the American Heart Association and Emeritus Stroke Association, the AHASA guidelines.
Okay, great. So our mission for this deep dive is to sort of cut through these sources, extract the key insights, and really understand what's new and what it means for managing AIS and predicting the future for patients. Let's start with those M2 occlusions. What's the deal there? Why are they important?
Well, okay, so blockages in this specific part of the brain artery, the M2 segment, they only account for maybe 4% of all ischemic strokes.
Seems small.
It does, but the thing is, they often hit in really sensitive areas of the brain, regions controlling things like speech or movement, crucial functions.
So location matters.
Exactly. So even if it's not the biggest vessel, a blockage there can have a really significant impact if it's not treated effectively.
And I remember reading that the 2018 guidelines, they weren't super strong on recommending mechanical thrombectomy for these M2s, right? Like physically removing the clot.
That's right. It was a weaker recommendation, a class IB. So there's been some debate. This new study, though, it directly compares two ways of doing that mechanical thrombectomy specifically for these M2 occlusions.
Okay, what are the two ways?
One is the, let's say, more traditional approach using a stent retriever. It's like a tiny cage, basically, that you deploy. It grabs the clot and you pull it out.
Okay, the stent retrieval.
The other is a newer technique called first stenting without retrieval, or FRESH.
Fresh. Catchy name. How do they compare them?
So they did a retrospective review, looked back at the records of 35 patients with these M2 occlusions treated between 2019 and 2023. 20 of them got the stent retriever, SRT, and 15 had the FRESH procedure.
Right.
And they looked at things like, how fast they restored blood flow, any complications, and importantly, how the patients were doing clinically about 3 months later.
Okay. Makes sense. And what did they find? What were the main differences?
Well, one really notable thing was speed. The FRESH technique was significantly faster at reopening the artery.
How much faster?
The time from puncture to recanalization, getting blood flow back, was about 35 minutes on average in the FRESH group. For the stent retriever group, it was more like 41.5 minutes.
Okay, 6.5 minutes doesn't sound like a ton, but...
But in stroke treatment, every single minute counts. You know the phrase, time is brain. Less time without blood flow generally means less potential damage.
Right. Absolutely critical. What about safety? Any differences there?
Yes, and this was pretty striking. There was a significant difference in something called asymptomatic intracranial hemorrhage. That's bleeding in the brain that doesn't cause immediate symptoms you'd notice.
Okay.
This happened in almost 19%, nearly 1 in 5 of the patients who had the stent retriever.
Wow.
But it occurred in 0% of the patients who had the FRESH procedure.
0. That's a big difference.
It really is a very interesting safety signal favoring FRESH in this study.
Okay, so potentially faster, potentially safer.
Yeah.
What about the actual recovery? How did the patients do long-term, or at least at 3 months?
Yeah, it looks like the FRESH group generally did better there, too. They used the standard scale, the modified Rankin scale, or MRS, to measure disability. 0 is no symptoms, 6 is death.
Right.
So a score of 0 to 2 is considered a favorable outcome, minimal or no disability. Almost 87% of the FRESH patients achieve that.
87%, okay. And the other group?
Compared to 55% in the stent retriever group, so a noticeable difference there.
Yeah, definitely.
And maybe even more impressively, they looked at excellent outcomes. An MRS of 0 or 1, meaning basically no significant disability at all.
Okay.
Nearly 67%, 2/3 of the FRESH patients achieved that, compared to only 25% in the stent retriever group.
Wow, 67 versus 25% for excellent outcome. That's quite substantial.
It really is. It suggests a pretty significant difference in how well people recovered.
So pulling that together, this study suggests that for these M2 occlusions specifically, this FRESH technique might be well, more efficient, maybe safer too.
That's what the data points towards, yes. More efficient and potentially safer.
So what does this mean for, for you listening, if someone has this type of stroke?
Well, I think it highlights how quickly things are evolving in stroke treatment. Even for these, medium-sized vessel blockages, this research suggests FRE-ESH could become perhaps the preferred initial approach for many M2s.
Leading to potentially faster treatment.
Exactly. Faster treatment, lower risk of certain bleeding complications. And that could significantly improve the chances of a really good recovery. It's definitely something stroke teams will be looking at and considering.
Okay, that's fascinating. A potential shift in how we treat these specific strokes. Now, let's kind of shift gears a bit. Talk about what happens after the clot is removed, because, even when the procedure itself goes well.
Yeah, the recovery journey can vary a lot, right?
Exactly. Some people bounce back remarkably well, others less so.
And that's a real challenge. Mechanical thrombectomy has been a game changer, no doubt, but we still see patients who don't have the outcomes we'd hoped.
So we need better ways to predict.
Precisely. We need to get better at figuring out early on who might be at higher risk for a poorer outcome. If we can do that, we might be able to, tailor their care afterwards more effectively.
And that's where the second study comes in, using MRI and radiomics and deep learning. Sounds complex.
It is pretty sophisticated, yeah. So this is another retrospective study. They look at data from 222 patients who'd had an AIS and undergone thrombectomy between 2021 and May 2024.
Okay.
They gathered clinical info like how severe the stroke was on admission using the NIHSS score, and they analyzed different types of MRI scans, T1, FLAR, DWI. These show different things about the brain tissue.
Right, the different MRI sequences.
Exactly. Then they split the patients into a training group to build their predictive models and a validation group to test how well those models worked on, like unseen data.
Okay, and you said models plural, so they didn't just try one thing.
No, they built 4 different models, which is smart. First, a clinical model just using standard stuff like the admission NIHSS score and whether there was any initial brain hemorrhage, stuff we usually have.
Kind of the baseline prediction.
Kind of, yeah. The second was a radiomics model. Now, radiomics is really cool, instead of just a radiologist looking at the scan.
Which they still do, obviously.
Oh, absolutely. But radiomics uses computers to extract hundreds, even thousands of quantitative features from the images. Things about texture, shape, intensity variations within the stroke lesion, stuff the human eye might not pick up easily.
So it's like quantifying the image details.
Exactly, turning the image into a big data set. Then the third model was a deep learning model.
The AI part.
Right. They used a specific type of AI, a 2.5D convolutional neural network based on ResNet 101 architecture, for those interested. Essentially, they trained this AI on lots of MRI scans and outcome data. The idea is it learns complex patterns in the images that are linked to prognosis, maybe even patterns we don't consciously recognize.
Okay, finding hidden signals. And the fourth model.
The fourth one was an integrated model. They called it CRD for Clinic Radiomics Deep Learning.
Ah, combining all 3.
Exactly. Taking the predictions from the clinical factors, the radiomics analysis, and the deep learning model and putting them all together.
Okay, so clinical, radiomics, deep learning, and then the combined CRD model. How did they perform? Which one was best at predicting a poor outcome?
Well, the integrated CRD model was consistently the winner in both the training and, more importantly, the validation group.
Okay.
They use a measure called AUC area under the ROC curve to gauge accuracy. 1.0 is perfect, 0.5 is just guessing.
Right.
In that crucial validation set, the CRD model hit an AUC of 0.908, which is really quite good.
0.908. How did the others do?
The clinical model alone got 0.874, radiomics was 0.805, and the deep learning model on its own was 0.757. So you see, combining them gave a significant boost in predictive power.
Yeah, 0.908 is definitely a step up, so the synergy, the combination is key.
It really seems to be. It's like each part brings a different piece of the puzzle. The clinical data gives you the starting point. Radiomics digs into the sort of micro details of the lesion on the scan. And deep learning finds those complex, perhaps non-linear patterns in the images. Put it all together.
You get a much more complete picture.
A more complete and apparently more accurate prediction. They also checked calibration, how well the predicted probabilities matched the actual outcomes, and the CRD model showed excellent consistency there too.
The study also mentioned a nomogram based on the CRD model. What's a nomogram and what did that show?
Right, so a nomogram is basically a visual tool. Think of it like a graphical calculator for risk.
Okay.
Based on the CRD model, it lets doctors plug in a specific patient's details, their clinical scores, maybe key imaging features, and it gives an estimated probability of a poor outcome for that individual.
So personalized risk prediction.
Exactly. And what the nomogram highlighted, based on the model, was that the patient's NIHSS score when they arrived at the hospital, that was the single most influential factor.
The initial stroke severity. Still number one.
It reinforces how critical that initial assessment is, yeah. But the other factors clearly add valuable predictive information on top of that.
Did the radiomics or the deep learning parts point to anything specific about the type of brain injury that predicts outcome?
Yeah, they did. The radiomic features that popped up as important, often related to like the heterogeneity, the variability or complexity, and the texture of the stroke lesion on the MRI.
So if the damaged area looks kind of messy or complex on the scan.
That might suggest a more severe underlying injury process, potentially leading to a worse prognosis. It's about quantifying that visual complexity.
And the deep learning.
The deep learning model was good at pulling out these complex features from all the different MRI image types together without needing tons of manual pre-processing. It shows the power of AI to learn directly from that rich image data.
Okay, so this CRD model, this integrated approach,
Yeah.
what's the potential real-world impact? How could this change things for patients?
I think it really pushes towards more personalized stroke care. Imagine, identifying patients very early on, right after their thrombectomy, who are at particularly high risk for a difficult recovery.
You could maybe intervene differently?
Potentially, yeah. Maybe more intensive rehab for those patients, closer monitoring for specific complications, maybe even enrolling them in trials for new therapies aimed at improving recovery. It also helps manage expectations. It allows for more informed conversations with patients and families about the likely road ahead.
That's huge. Using AI and detailed imaging analysis to really tailor that post-stroke care.
Okay, so we've looked at a specific treatment technique, FIRS, and this advanced prediction model, CRD. How does all this fit into the sort of the established bigger picture, the AHASA guidelines for stroke care?
Right, those guidelines are really the bedrock. They provide this comprehensive framework covering everything from the moment someone suspects a stroke all the way through rehab and preventing another one.
And speed is always central, right? Absolutely. A core theme is acting fast. Public education recognizing symptoms, calling 911 immediately is critical. EMS treating stroke as high priority, getting patients quickly to the right hospital, all that is paramount. Minimizing that door-to-needle time for the clot-busting drug, alteplase, is a key quality metric.
And what about deciding which hospital? Especially if thrombectomy might be needed.
That's a bit more nuanced in the guidelines. Generally, it's transport to the closest alteplase-capable hospital, but the guidelines acknowledge there's still some uncertainty about bypassing a closer hospital to get to a comprehensive stroke center that does thrombectomy, especially if multiple alteplase options are nearby.
So it's ongoing discussion.
It is. But they do give a moderate recommendation that Class II, again, for developing protocols so EMS can potentially identify patients with a likely large vessel occlusion and LVO in the field.
Right.
The idea being maybe those patients should go directly to a thrombectomy center. It's an area that's definitely evolving.
But once the patient gets to the ED, what are the guidelines focused on?
Well, tracking that door-to-treatment time for fibrinolysis is important for system improvement, and they highlight the growing role of telemedicine telestroke.
Especially for hospitals without on-site experts.
Exactly. Using remote experts for reading scans, making decisions about IV alteplases, that gets a thumbs up. Another II back recommendation.
And then for managing the patient once admitted, what are some key principles? Oxygen, blood pressure.
Yep, fundamentals. Keep oxygen saturation above 94%, but don't just give oxygen routinely if they're not hypoxic. Blood pressure needs careful management-specific targets before and after alteplase. They even name preferred meds like labetalol, nicardipine, clevenapine.
Okay.
And for the thrombectomy itself, they clearly prefer stent retrievers over older devices, and the goal is fast, good reperfusion, getting that blood flow back to MTICI 2B or 3 as quickly as possible. That's a strong Class II recommendation.
What about other things like blood sugar, nutrition?
Both crucial. Treat low blood sugar, hypoglycemia immediately. For high blood sugar hyperglycemia, aim for a target range, generally 140-180 milli-GDL. And nutrition is key. Start enteral feeding, like through a tube, within 7 days if they can't swallow safely.
Right. NG tubes first maybe, then something more permanent if needed?
Yeah, nasogastric tubes initially, but maybe a PEG tube, percutaneous gastrostomy, if swallowing issues look like they'll be long-term.
The guidelines also cover things often seen as secondary but vital for recovery, like skincare and rehab.
Absolutely vital. Regular skin checks using objective scales like the Braden scale are recommended. Minimizing pressure, using support surfaces, good hygiene, all important.
And rehab.
Crucial. Early rehab in an organized stroke unit with an interprofessional team is strongly recommended. The intensity should match what the patient can tolerate and benefit from. And before discharge, a formal assessment of ADL's activities of daily living communication, mobility. That's essential.
What about managing complications like brain swelling? That can be life-threatening.
Yes, the guidelines address that. For swelling after a cerebellar stroke, causing hydrocephalus fluid buildup, a ventriculostomy to drain fluid might be needed. If that cerebellar swelling compresses the brainstem, surgery to remove part of the skull, a decompressive craniectomy, is often recommended.
And for swelling after big MCA strokes.
Yeah, for large strokes in the middle cerebral artery territory, especially in patients over 60, if swelling causes neurological worsening despite medical treatment, decompressive craniectomy may be considered within 48 hours. That's a II recommendation, reflecting more uncertainty.
And finally, preventing the next stroke.
Huge focus. Start smoking cessation support counseling, nicotine replacement while they're still in the hospital if they smoke, educate patients about their stroke, risk factors, prevention, and participation in stroke data registries and quality improvement efforts is encouraged to keep driving better care.
Okay, so let's try and bring this all together. It seems like the FAES study for M2s offers a potential refinement, maybe a better tool for that initial treatment step in some patients.
Yeah, potentially making that crucial reperfusion step faster and safer for that group, fitting right into the guidelines' emphasis on effective, rapid treatment.
And the CRD model study, using AI and radiomics, that's pushing the boundaries of predicting what happens after treatment.
Exactly. It offers this glimpse into more personalized post-stroke care, using advanced tech to understand individual risk better and potentially tailor interventions. That aligns with the overall goal of continuously improving outcomes.
So it's not just about the initial fix, but also about predicting and managing the recovery journey much more precisely.
Precisely. It's about optimizing care across the entire continuum.
This has been a really fascinating deep dive. It's clear that research is constantly moving, pushing things forward, offering, real hope for better outcomes after stroke.
Absolutely. It's a dynamic field, and integrating these kinds of innovative techniques and technologies like FRESH and advanced predictive modeling, it holds tremendous promise.
So maybe a final thought for you, the listener, to mull over. With all this rapid progress, better treatments, better prediction, what do you think are the biggest hurdles we still face in actually getting these advancements to every patient who could benefit and getting it to them quickly, equitably? Something important to think about. Thanks for joining us for this deep dive.